If you're listening to this podcast on YouTube, for a better experience, switch to the video version. The link is in the top right corner of the video and in the episode description. Hello and welcome. I'm Fernando, a GP in the UK. In today's episode, we'll be looking at the NICE updates published in May 2025, focusing on what is relevant to primary care only. We've got another short episode today, as there's only one clinical area to discuss: new advice on the cancer recognition guideline. Right, let's jump into it. And this update refers to the early detection of upper gastrointestinal cancers. It only touches on the recommendations for esophageal and stomach cancers. And it will not really change our practice very much, given that it affects the referral process only. The difference is that before, when someone developed red flag symptoms, we were advised to refer them for an urgent direct access upper GI endoscopy to be performed within 2 weeks. Whereas now, the advice is to refer them using a suspected cancer pathway. Is there a real difference? Well, in fact, there is. Let's have a look at it. The main difference lies in who triages the referral, the urgency and the coordination of care. For example, in an urgent direct access upper GI endoscopy done within 2 weeks, the GP directly refers the patient to the endoscopy service, who triages the referral without specialist input. Also, although urgent direct access endoscopy is expected within 2 weeks, it's not formally tracked like a cancer pathway. And finally, there is no coordinated follow-up if something is found. The GP will receive the report and must then arrange further care. On the other hand, a suspected cancer pathway means that the hospital cancer referral team triages the referral and coordinates and tracks the process. This often means that the patient is seen or tested within 2 weeks, but the formal definition of a suspected cancer pathway referral is that the patient has the diagnosis of cancer either confirmed or ruled out within 28 days of the original referral. The advantage of this model is that if a cancer is found, follow-up is already embedded in the system. So that is really the only change. Since today's episode is so short, let's take the opportunity to review the recommendations on upper GI cancers. For esophageal and stomach cancers, we will refer them on a suspected cancer pathway if they have dysphagia or are aged 55 and over with weight loss and they have any of the following: upper abdominal pain, reflux or dyspepsia. We will consider non-urgent direct access upper gastrointestinal endoscopy in people with hematemesis and in people aged 55 or over with treatment-resistant dyspepsia or upper abdominal pain with low hemoglobin levels or raised platelet count with any of the following: nausea, vomiting, weight loss, reflux, dyspepsia and upper abdominal pain. Or nausea or vomiting with any of the following: weight loss, reflux, dyspepsia and upper abdominal pain. In terms of pancreatic cancer, we will refer if they are aged 40 and over and have jaundice. And we will also consider an urgent direct access CT scan to be done within 2 weeks, or an urgent ultrasound scan if CT is not available, in people aged 60 and over with weight loss and any of the following: diarrhea, back or abdominal pain, nausea or vomiting, constipation or new onset diabetes. And finally, in terms of gallbladder cancer and liver cancer, we will consider an urgent direct access ultrasound scan to be done within 2 weeks in people with an upper abdominal mass consistent with either an enlarged gallbladder or an enlarged liver. So that is it, a review of the NICE updates relevant to primary care. We have come to the end of this episode. Remember that this is not medical advice, but only my summary and my interpretation of the guidelines. You must always use your clinical judgment. Thank you for listening and goodbye.